We'd like to open it up for questions. If any of you would have a question, please go to a mic and address your question to one of our speakers. I'd like to start the ball rolling with a question for Laura. The patients who are on your MCCM program who do eventually transition to hospice, do they have a longer length of stay on hospice, or do you know if that's the case?
I'm not sure if I'm allowed to share specifically, but I'll say that it's not dramatic like we would see in this program because they are already hospice eligible when we get them. So I think the fact that we're still saying, well, you have to be 6 months or less to get this program. Well, the same barriers that I talked about at the very beginning of how do I identify somebody who's 6 months or less, they are still there. And so we're still getting people more in the later stages.
Thank you.
Hello, my name is Paige Bingham. I'm with Allina Health in Minneapolis. We serve both Minnesota and Wisconsin. We are just announced as an accountable health community, one of the 32, and previously were one of the remaining 9 pioneer ACOs. So our CEO, Penny Wheeler, has done a lot to help advance population health within our communities. And I'm specifically interested in the idea of using aides or a community health worker on some of these interdisciplinary team and outreach efforts, whether it's in more the pro-health care management and palliative space, or whether it's in the care choices. Will be part of the phase 2 on care choices. And wanted to know specifically, Laura, I think you had mentioned that there were aides on your team, or Dana, again, as you think about your interdisciplinary team and how to help extending that trusted relationship on a monthly basis in people's homes.
Well, yes. I mean, I think aid support is critical. I think that's, that type of care is what helps keep people at home. And that the fact that it's so poorly reimbursed is a problem. I think that so we use our hospice aides to help support in this Care Choices program, but it's not nearly to the degree that they're providing support in the hospice setting, and a lot of that is just due to limitations within the model and the payment and staffing. But I think that idea of using community resources and sort of training non-clinical professionals to help provide additional support in the home, I think that's really going to be essential as we build out these home-based palliative care models, that it's not just about the nurse and the social worker and the physician, it's what is already existing in the community and how do we pull those in, and it's going to look different for each patient depending on what their community looks like.
We use volunteers. We have a very active volunteer department, and so we consider our volunteers part of our team. And many of them work. They go out in the evenings or they go out on weekends. Some are Reiki therapists, massage therapists, professionals, older people, young people, college students in the summer. We have a lot of them who join us. And so we bring them in as part of the team, and they have patients that they then go out and see. They are able to come in and meet with us during the one-to-ones on their patients. They come to team meeting once every 2 months just to be part of something. So we find that that's really quite helpful. Regarding home health aides, it's a real challenge, and that's what families seem to want. That is what families want most, without question. Many of our families can afford to privately hire home health aides. They just didn't know that they needed to now. So we do help them realize Medicare won't pay for it, their insurance won't pay for it. We do help them figure out how to get them. Those with Medicaid, we also work with their MLTCs and others to get home health aides or do a Medicaid application. But you're quite right, it's a real gap, and it's what families want most and need most and more of.
Thank you. Question to my right.
Hello, I'm Mark Gans with Cambia Health Solutions. And first, I just want to thank you all for really strong presentations that reflect the excellent work you guys are doing in your organizations. My question is to Deborah and to Kathy, which has to do with sort of institutional culture. Both within your institutions and what you see in the broader landscape of where you work. What do you see as being kind of the greatest cultural barrier that needs to be, corporate culture, shall we say, or institutional culture barrier that needs to be overcome with respect to making sure that every child and their family gets the palliative care that they need? And what are your thoughts about what would be sort of the game changer that would change that over the next 10 to 15 years?
So I think that the idea that children die, even though we both work in major children's hospitals, that there is still a culture more amongst our physician colleagues than nurses at the bedside, that it is still hard to believe that there isn't something else that can be done. So that whole idea of, and we both use this terminology a lot, there's always something you can do to somebody, but are we doing it for somebody? So that the culture of we're not giving up, we're redirecting our hope, we're redirecting our care, those kinds of things. So some terminologies to help, I think, people feel successful in their work, even when their patient doesn't survive. I think the other thing that happens in our institution is this idea that we don't want you to take our patient. So we're very clearly a consultative service, as is Debbie's program, so that we augment what the primary team is doing. And that, I think, helps supports the medical team, but it also helps support the families, because we don't want to take them away from their cardiologist, from their nephrologist, from their neuromuscular physicians. So to kind of help balance that. And then when I look forward, I see the biggest gap, and what we need to do is exactly what both our programs are doing with involving community hospice partners to learn how to take care of children. Because when we go across the United States and we speak at pediatric palliative care conferences or pediatric nursing conferences, people will raise their hand and say, but we don't have a pediatric hospice in you name the city. And that's because they don't exist. So instead of saying they don't exist, we need to be innovative, take our program, take Debbie's program, which really are very similar in terms of our community hospice engagement, and encourage those people, educate those people, give those community hospices the resources they need so that they can take care of the whole family, including those children.
And I would echo what Kathy said, but I also want to talk about that group of sort of the forgotten, and that are those adolescents and young adults who fall in that gray zone of, the 21 to 26-year-olds who aren't covered by Medicare. And I'd like to sign up for both of your programs now for myself. And they're not covered under concurrent care. And so they're in limbo. We have a young man in our hospital right now who is 21. He has a glioblastoma, a very aggressive brain tumor. And he's a single mom who also is taking care of her very frail elderly mother at home. She can't get home health aides. He doesn't fall under concurrent care. He has a commercial insurance. And he's stuck in our hospital because he wants to go home, and we can't get him the support that he needs. If he was a younger child, I have all kinds of options. If he was Medicare eligible, sounds like we have a lot of options. So those kids that are in that, he'd probably hit me if he heard me calling him a kid, but these young adults that are caught in this limbo area and aren't covered by anybody, and they're forgotten. And I think we need to remember them, and we need to do better about taking care of them.
Hi, Joanne Lynn again. Just a quick question and a comment to ponder for Dr. Patel. In passing, you said an interesting phrase. You said that the MCCM it turns on it being no surprise if the person dies within 6 months. If that's true, I would be overjoyed. But isn't it still just the standard hospice 6-month prognosis?
It is still based on the hospice criteria. Yes. So
okay. I had hopes that maybe there was some little place where the no surprise question was functioning.
I wish we could do that. Yes, but this is still sticking to those requirements.
The issue for, I think, all of us to ponder, I noticed that in your slides, Dr. Patel, you had curative in quotes, which I think is a profound observation. Ordinarily, we have nothing curative to offer. We have stuff to offer that might change the course a bit, but it's not going to cure. What would happen if we actually kind of put forward that you're giving up nothing to go into hospice care? That, curative, there isn't curative on the deck, so you aren't giving up anything. Now, you still want the Medicare or the insurance payment for the routine stuff and the insurance payment for hospice, but that would be a different question if we hadn't put up this barrier that seems to turn down all kinds of stuff. Whereas if we just said, you're turning down nothing, there isn't a cure around.
Over to my right.
Thank you. Christian Sinclair from the American Academy of Hospice and Palliative Medicine. Thank you all for your presentations and sharing with us your innovative programs. I think, Deborah, you had mentioned an app that the parents have that they can start to problem solve on their own through a trusted, vetted source. Going off of that, and this is open to everybody, how are you, or are there ways that your programs are incorporating the patient and the family voice in developing these programs and actually not just, we got a good idea from a parent or a family member, but they're actually helping you lead and develop these programs?
Absolutely. Absolutely. We have involved parents in the development of this app, but also in our program from day one. We've had them come in, we've had them talk about what's most important to them. We talk about quality metrics in palliative care. For us, we want to know what's most important to you as a family. We heard from our very eloquent speaker this morning that she wanted 24/7 access, and that certainly is one of the things, and that's where this development of this app came from. But 100%, at least in our program, we are incorporating the parent and the child's voice from the beginning.
We're working right now to understand the patient experience while they're getting home-based palliative care. Not a bereavement survey, not a hospice survey, but we really want to know for people in our program for 3 months or longer, how are they experiencing this program? So we're trying to develop, and we're working with Press Ganey on a survey to identify, the elements of the program that are working. Do they find that it's helpful? So we're in the process of, it's a telephonic survey. It's about 10 questions. So we're using patients right now to test the survey. So we call them, and they know they're helping us build this survey. One of the things that health plans like quite a bit is a net promoter score, likelihood to recommend, and it's from 1 to 10. And one of the things we're noticing as we're testing this with patients and families is they love home-based palliative care, and they love their nurse, Mary or Andrea, but their quality of life is really poor, and they're very tired a lot. And so they love the program, and they give it an 8. And in the net promoter score world, that ends up being a 0 because you take the promoters minus the detractors. And so it's just very interesting as we try to figure out how do we know from patients and families if what we're doing is helping them.
Thank you. Leslie.
Hi there. Everybody here was talking, especially in the Medicare world, about comorbidities. And if you look at the people who are the highest utilizers, a lot of them have severe psychiatric comorbidities, substance abuse, bipolar disorder, either they or their families. So I'm wondering I'm from University of Virginia. I do office-based palliative care and some telemedicine myself. That's our most challenging area. And because if we talk about resources that aren't there in the community, unless people can pay a huge sum of money, which my patients can't, those kinds of services are really hard to access. So I'm wondering if you guys, not just for the depressed people or the sad people or the anxious people, but the people, who have been psychiatrically admitted and they have metastatic cancer or end-stage CHF, or they have cancer and pain and a history of IV drug abuse. And I'm wondering, I don't find those people to be that rare, and I'm wondering if you guys have dealt with that at all. Thank you.
Well, certainly that's something that we deal with. I agree, it's not rare. I think in the hospice world, I kind of think that, in theory, hospice, a lot of people think hospice, it's this gentle, wonderful place where people get so much support, which is true, but it's also where a lot of the pre-existing family dynamics, challenging mental illness, social issues that come out and come out full force. And so I think having skilled licensed clinical social workers who have experience with those things is very helpful. And I think it's going to be more important to figure out how do we partner our home-based palliative care or hospice services with whatever existing supports we have in the community. And one of the, I sit on this kind of high utilization committee for one of our hospitals, and I sat through a lot of meetings, and maybe one or two would have a palliative care issue. I get really excited because I could contribute. A lot of it was homelessness, was mental illness, was drug use, and those are very persistent issues. But those people are caring for people who have metastatic cancer, or they're a family member. So it's all intricately connected, and I think we've tended to separate out the specialties, and we really need to figure out how to bring them back together. I don't have a great answer, because I think it just, as a community, we haven't done a very good job taking care of those issues, but I think that needs to be continued to be discussed.
So one approach we've used, and again, it's a pediatric setting, so a bit different, is to infiltrate from within. So in our primary palliative care training, we invited people from all disciplines and all practice areas. And we had two people from psychiatry who were interested, and they came to our training, and we sort of ignited that passion in them. And so now they are our go-to people when we run up against some of these issues. So it gave them sort of a passion and something different to sort of focus on. And they're also then, when they have inpatients or outpatients that are coming to see them in their psychiatric practice, and they're noticing, hey, this patient might have some palliative care needs, they in turn are reaching to us. So we infiltrated.
Could they move to Virginia?
No.
Dr. Colleen.
Hi, I'm Colleen Talon from Lee Health. I have a question for you, Dana. In your opinion, what markers have been most valuable in identifying the community patient proactively?
I'd say two things primarily. We certainly look at people with 2 or more hospital admissions in the recent past. So people with 2 or more admissions in the past 3 to 6 months have a 50% chance of a third admission or more. So that's number one. Bless you, James. And number two, we look at markers of frailty. And so people that have ordered a walker, decubitus, dementia, those kinds of markers through claims, and trying to get the algorithm that looks at disease burden, counting up number of chronic conditions with that hospital bed and claims. Unfortunately, we really don't have access to functional assessment through claims like activities of daily living, social isolation. Some of the social determinants of health are not really available at all through claims, and we also don't have access to the minimum data set, which is a maximum data set from a subacute rehab stay. But what we can glean from claims, I think, is really useful. And when we couple a few things together, like use of home oxygen with some of those markers of frailty, with 2 admissions in the recent past, those are very high predictors of unmet palliative care need.
Dana, what is the lag time with getting that information versus real time?
Right. So 2 things. So we get the auth files from the health plans we participate in, and real authorization files in real time, maybe a day or 2 lag there. So we know who's in the hospital in real time in our shared savings programs with a predictive risk score. For Medicare shared savings program, ACO, it's about an 8-week lag. So sometimes with our algorithm, we do call people to enroll and they've died because the algorithm performs very well, or they're in hospice already, but more often than not, it's a pretty good targeted population with about a 40% 1-year mortality rate compared to about a 2% average for the population.
Hi, I'm Pat Bomba. I'm Vice President and Medical Director for Geriatrics at Excellus Blue Cross Blue Shield. I want to thank the panel for a great conversation. My first question goes to Dana. In terms of looking at HIPAA-compliant apps, in your experience, how did you choose what you use? Because I think if we're going to overcome some of the barriers of workforce, that telepalliative consultations, as well as the ability to have advanced care planning conversations by primary care physicians, is going to be really important. But there are several out there. what did you look at and what did you choose?
There are a couple out there, and we'll hear a little more about telehealth later today, I'm sure. We happen to use video, VIDYO. There's Zoom, Skype for Business is another one. Truthfully, we were using FaceTime until our lawyers shut us down because and FaceTime was oh so easy, so of course that was shut down. But this is the one we chose. I think they're all quite similar. I've used them all. But they do require you to download something onto a smartphone. It requires you to have a device, know how to download something, and then connect into the room. Once we've gotten a patient or family member in there once, they love it, and we use it all the time.
Yeah, I appreciate your honesty because I've had to kind of share the legal perspective of FaceTime. And I just wanted to make a comment on really getting some coverage, insurance coverage for folks with pediatric palliative care. So our organization, Excellus, Blue Cross Blue Shield, worked more than a decade ago to provide a model working with pediatric palliative care and community organizations and just said, we're going to pay for it, and began to use that model to drive change with other private insurers and for our state Medicaid system to look at it. So I think the model you described is something we've done for over a decade, and it does have positive outcomes, but it also does blend in community partners that really see the need and embrace the need, both for the pediatric but also the perinatal population. So thanks for the work you're doing.
Thank you. And we certainly were doing our work in the early 2000s, and Blue Cross Blue Shield in our states was also very helpful. And then we did use them to talk to other insurance companies that said, well, we don't do that. And we'll say, well, this is how it's working somewhere else. So although the Affordable Care Act was really helpful because it gave us a place to use now differently, but I think that both Debbie and I were doing this work sort of one-on-one with insurance companies to provide that care. So thank you for the work you do.
Yes.
Thank you. I'm Rebecca Kirch with the National Patient Advocate Foundation. I'm so thrilled we're 2 for 2 in workshops in bringing infants and children to the grown-up table. That infiltration is alive and well and so important because there's this significant opportunity for adult and pediatric care to learn from each other and build off each other's best practices. I wanted to build off the question that Mark Gantz just asked, talking about piercing the culture, to think about the C-suite, because our programs still are very dependent on hospital funding. So I'm wondering if each of you on the panel could talk about, and those in the room too, a little bit about what is the one key point of all the beautiful bullets of the benefits of palliative care that makes the eyes shine of those business leaders that say, yes, we're going to invest here.
I guess I'll start. You know, it really, one thing that's important is to recognize who you're talking to. So I came from a health system, a large health system in New York, and started the inpatient palliative care department there in a fellowship and a palliative care unit in New York in a large hospital, and had a really great idea that, wow, why don't we think about starting home-based palliative care, because I've heard it reduces hospital admissions. And that didn't go over very well, you know, in a very large 950-bed hospital with some capacity. So in an ACO model, though, where I am now, and we make money if there is shared savings to be made by reducing the medical loss ratio with health plans, for example, or having good outcomes with CMS, we share in savings where there's better alignment. That's a really different kind of conversation. And so by talking about how good care, good high-quality palliative care ends up costing less money, I think is a real message when there's perfect financial alignment. It does not work well, though, when there's money to be made on the hamster wheel and the churn and admitting people. So when there's perfect alignment is the sweet spot. And I think there's just such amazing opportunity to work with folks where there is more accountability or risk, because then there's really a desire all the way around to do things for people at home that are innovative, like providing 24/7 care, like doing telemedicine where there's no reimbursement for that right now, or sending social workers to the home, again, not really billable. So I think when there's perfect financial alignment, there's this amazing opportunity to innovate.
I would add, So we are a hospice organization, but we also provide inpatient palliative care at a couple of hospitals in our area. And through that, we've been able to get some funding from them as they've sort of started to realize over the past couple of years that, wow, this is making a huge impact, not only on patients, but also on their bottom line. We're saving a lot of money in readmissions. We've been able to do some pilots and kind of, they're seeing the need to extend this into the community, which is what we've already been doing, but we'd love to have some additional funding to support it. But one thing that really struck me the other day is I was in a meeting with some people who were in the C-suite, pretty close to it, and one of them said, you know, I just want to say, you all are taking care of my mother-in-law, and it's just been such a godsend. And I think that I've heard other people speak as well. I feel like everybody has a story. So people in the C-suite have families. A lot of them have gone through an illness. They've been through a good story or a more difficult story. And so I think they're definitely going to be interested in cost savings, but I think the story and bringing it back to that personal experience goes a really long way. So trying to get to that is important.
And I would completely agree. I think it's the story. It's we can talk all day long wherever we're educating, and even today, this whole day, my guess is what we're going to walk away with was the patient story we heard this morning, and that's what we're going to hold on to. So in pediatrics and perinatal, I think it's the story, and it's also focusing on it's the right thing to do. When a family can come back and say, "We never knew we could go home, and you let us go home." Like that's what makes a difference. And then, and telling that story to everyone that will listen. I mean, so talking to going to a faculty meeting with a parent story and letting that person talk to the faculty, the physicians across the board. Because when a family says it made a difference, and then in our case this week, when they actually brought the difference, when Jody brought her daughter Kate to show us what, after 103 days in the NICU, that she was a thriving child, then people will think differently. So I think it's that idea of telling the story, and then remembering it's the right thing to do. I mean, cost saving is important, and I think that's part of the work that we do, but also that idea that this is the right thing to do, and then the story. It's always the story.
I would say that myself or my team, we're not the best people to tell the story. It's the child or the family themselves. And I think in pediatrics in particular, thinking about siblings and having that sibling talk about what it was like to watch their brother or sister go through this, what it was like to see what happened in their family, and how palliative care helped them, tells a powerful, powerful story that we just can't get across in a meaningful way. So the stories, the stories, the stories.
Good morning, all. I'm Pam Hines, and I'm from the Children's National Health System here in Washington, D.C. And I am so grateful for how you have combined passion and other forms of data to create these very wonderful programs. So as the triple aim framework has expanded to the quadruple aim framework, and I'd like to ask you to speak to the principle of sustaining the well-being of the healthcare providers who are embedded in your programs. And could you speak to this from other forms of data, including budget, the elements of budget that support your efforts to sustain team members, and also perhaps other creative elements of a program that come from within or external that you are using to sustain your team members? And thank you.
The easy question comes from my own institution. I think that's a challenge. My work started from nurses at the bedside expressing moral distress, that we have to do this better. We have to help these patients and families to suffer less and to find more meaning in what they do, but it comes at a cost to ourselves. And I think often of a story, as a mother and spending extra hours at work taking care of those patients, where that 5 extra minutes for one patient turned into 3 hours for the 10 patients that I gave that 5 extra minutes to. And my son saying, Mom, it's okay. I understand what you do is important, but I like stick the knife in and twist it. Why don't you? So I think that we need to be very proactive in our interventions for staff. And in our program, we are very purposeful. In our palliative care team, we have regular self-care activities where we try and talk about ourselves, not talk about ourselves, talk about what's going on. Well, sometimes it's talking about ourselves, but talking about what's going on. But we make purposeful activities to help us really center ourselves and to recognize the work that we're doing is important. But we, as we tell our parents of our children, you can't take care of your child unless you take care of yourself. We can't take care of our patients and families unless we take care of ourselves too. So it is creative and trying to think about how you can budget for these kinds of things. I know that your own work in looking at providing places for nurses and staff to nap during the night shift. I almost want to start working the night shift again so I can take a nap. Things like that, having a place where staff can go to spend some time, whether that's after they've taken care of a child who's died or they're just having a very difficult day dealing with whatever those dilemmas are. I will be very honest with you. Some of the more programmatic aspects of keeping your team running, those budget items seem to come to the top. And the interventions that we do for staff, that budget seems to fall to the bottom. So in the interest of full disclosure, that's an area of real weakness for us.
I think one of the things that we have realized as our team has grown, both our team and the hospital, and this really started with a project in our neonatal ICU about how do we support those nurses, because those babies are getting tinier and tinier and it's difficult. So we're really trying to focus on what can you do in the moment. And we went to the nurses and sort of said, what do you do on a daily basis where you can stop and use that? Because we used to wash our hands. Remember, we would wash our hands under warm water, and now we use the hand sanitizer and quickly rub our hands while we're going from one patient to the next. So even that very basic thing. So some of the things and these are from the nurses, they made their break room a no complain zone. So if you're having a bad day, you can go complain to somebody else somewhere else. But their break room, if you start complaining about somebody, I can say, oh, actually, this is the no complain zone. And it gives, so now they have a place where you can go. They talk about logging onto your computer and how often we use our password. So if you're going to Paris in 2018, make your password Paris 2018. So every time you're using your password, you're thinking about where you're going. Every time they change a diaper, they have these little codes in the rooms. They don't actually have a picture of a diaper, but they're supposed to think, where are my shoulders? If they're up around my ears and when I'm changing that diaper, I need to put them back down where they belong. So trying to find things throughout the day, because we'd love to have a massage therapist come at the end of our day. But that's also not practical, because even when they do come, you're in the middle of something. So trying to incorporate self-care into something we do every day and then remind each other. And I think that's where the trust of your team comes, not your palliative care team, but your entire care team. That if I recognize my colleague is really having a day, to try to find a space to remind her of that and what can I do to help, and look at our boundaries and how do we work hard when we're at work, but always make sure our life away from work is supposed to be better. And I always tell people, if you enjoy coming to work more than you enjoy not coming to work, you should think about that. Because I just think you should, because for some people that's sustainable. For me, it's not. And that's never been a problem. But I think for some people, when you're learning to do this work, it's that balance.
And I'll just add a quick thing. I think we also have a kids program, and so a lot of what you've said has really resonated with me. And they have a room, and it started off as a really tiny program, so they had a cubicle, and then they've expanded to a little bit bigger room, and now they're in a little bit bigger room. And that room, it's amazing that it's just unlike the rest of our hospice organization. So you walk into that room one day after they moved in there, and there's like giraffes in the windows, and there's stuff hanging. It's joy and happiness in there. There's beanbags on the floor. You take your shoes off at the door, and it's a cultural difference. And I think our other people in our hospice have started migrating into that room sometimes when they feel like, "Oh, I just need a little bit of infusion of smiles and happiness," because that's what you feel when you're in there. So I think having that physical space is really important.
So we do three things. One is we have Fun Fridays the last Friday of every month, and we usually play charades, and we're a very competitive team, but we use an app for charades, and so you put it on your forehead, and you have to do the thing, and so it really ends up being a lot of fun. So it's once a month, and it really just sort of punctuates our month. The second thing we do is every quarter we have a wine and cheese party or a cocktail party in my backyard, and so everybody just comes over, and we just really decompress. And then the last thing that we do is we have a group text. And so sometimes people will just stop and take a picture where they are of a flower or the snow or whatever it is. And we also tell a lot of jokes in the group text, nothing patient related, but we just put a lot of jokes in, and we use humor quite a bit in the group text. And so those are three strategies that we found to be very useful.
To add one more thing is that our chaplains have something called Comfort Corner, which I totally forgot about. It was one of our Panda Cups QI projects, actually, where it's a mobile room in the sense that it's a cart that has music and art supplies and chocolate and just things to make you feel good. And then we also have dance parties. So on the different units at different times, it's sort of spontaneous. There'll be a dance party, and I'll be honest with you, it's staff dancing a lot more than the kids are, but we have a lot of fun.
Hi, I'm Bruce Smith. I'm one of the medical directors for Cambia Health Solutions, and I'm also a longtime palliative care doc and have been a hospice medical director. A lot of times formal programs like hospice programs have a lot of support for staff, and have ceremonies every week or a month or something like that at IDT. Because of the nature of the work, we are always grieving and saying goodbye to patients that we've cared for. One of the things, as we have more and more palliative care programs now, and we interact with folks in the usual medical community, so pediatricians in the NICU or even in the office who are having to deal with the fact that they have children under their care who are dying too, or cardiologists or pulmonologists or nephrologists or you name your ologist for adult care, their patients are dying too, oncologists in particular. And in my work, talking to our contracted medical docs, one of the things that usually doesn't happen is any sort of a remembrance or a support group or anything like that at the oncology office, the cardiology office, you name it, or the pediatric office. So my question is whether any of you are doing anything to help support that fourth bullet in the triple aim of how do we help support our other colleagues who are not engaged in palliative care directly. How do we help move some of our learnings and our support structure and what we know works in our own practices? How do we help move that out to our community docs so that they can help sustain in the course of their day as their patients are going through serious illness and maybe dying someday too?
I think you bring up a very important part about the community. We do remembrances and self-care things in the hospital. So with the oncology team, with the cystic fibrosis team in the NICU. So I think we're pretty successful there. But the community pediatricians are a group that we're not really reaching out to as much. We hope to do that in the future. But I think your point is very well taken, that those are folks need us, and they need that help and support just as much.
Thank you. I'm Türkan Gardinier from Pragmatica Corporation. I have worked as a statistician for quite a number of years, and it has been illuminating for me to know about all these programs in palliative care. And I was wondering whether there's any efforts or developments or existing materials of collaboration or making your data available to centralize the databases, for example, with National Institute of Aging or other community programs that other people like us don't usually delve into in active programs that are available for others to be aware of.
Yeah, I think, and Diana's here, but the Center to Advance Palliative Care, which has a wonderful registry and handle on inpatient palliative care programs, is now going to be able to tell us soon, hopefully, what the field is looking like with community and home-based palliative care programs as we start to take a registry around that and get a pulse of what's going on. Because you're right, we don't really have a good handle on what's going out there, and a lot of changes even in the past year of who's entering this space. So I think we'll know more through the Center to Advance Palliative Care on that.
Thank you.